Hi, this is Dr. Bernstein with another session of Dr. Bernstein's Diabetes University. In response to a request from our audience, we're going to talk today about neuropathy, diabetic neuropathy. Now, this is a very broad subject. It covers virtually every nerve and organ in the body. In fact, my physician 50 years ago was editor of a textbook on diabetic neuropathy that was about 500 pages long. So there's a lot that can be said. The nerves that are first injured by high blood sugars are the longest nerves of the body. I don't know for sure why long nerves get hit first, but they do, and so one of the earliest things you can perceive would be loss of sensation in the feet. And this involves sensations of things like light touch, vibration, hot and cold, even pain. I very frequently find people where I try to squeeze the Achilles tendon at the back of their heel and they have no pain. And that's supposed to be very painful if you squeeze it hard. Now, the big complaint about neuropathy in the feet, on the other hand, is pain rather than numbness or lack of sensation. Many diabetics experience burning pain, electrical type tingling, prickling pain, or pricking pain, and some of them can't sleep because of the pain. Now, the marketplace is loaded with drugs that are meant to combat diabetic neuropathic pain. And that really is not a treatment. It's treating the symptoms, not the cause. I have, in my 30 years of practice, never needed to use any of these drugs that numb the sensation, because normalizing blood sugars usually undoes the neuropathy. In fact, I should say always undoes the neuropathy. It's a matter of time until the pain goes away. Now, nerves regenerate in a young, healthy, non-diabetic at the rate of about 1 millimeter per day. So if someone still has high blood sugars, they won't regenerate. If you have almost normal blood sugars, they might regenerate at the rate of 1 millimeter every 5 days. And by what does a millimeter mean? It's a measure of the distance from the point of discomfort to the spine. Now, so that could be 3 feet. Or about a meter, which is 1,000 millimeters. So if you're lucky, it could take 1,000 days to recover full performance of a nerve that goes down to your feet. Now, what we see with people who have pain is a relatively rapid diminution of the major pain, and then gradual diminution over a period of maybe 1 to 3 years. 3 years would be about 3,000 days. I'm sorry, would be about 3 years would be about 1,000 days. So if you have painful neuropathy in your feet, we could see a rapid initial improvement with slow improvement thereafter. There's another kind of neuropathy which works sort of in the opposite way. If you have totally numb feet, which is quite common, and cannot feel anything, and you start normalizing blood sugars, or you achieve normal blood sugars, as the nerves resprout and you begin to have sensation again, you can also experience great pain. A podiatrist who had this described it to me as lancinating pain, which is an extreme of pain. However, since I had warned him about this, and he expected it, and I said, it's going to be with you for maybe 3 or 4 months, but will go away as your nerves heal. He put up with it, and it's much easier to put up with something that you know is getting better. So we see that when you normalize blood sugars, numb feet initially become painful, and then later on the pain goes away. If you want to use a painkiller then, like Lyrica or one of the other preparations that are on the market, you could try that, but I would recommend that, knowing it's going to get better, that you put up with it. There are many, many neuropathies. For example, very common is what they say on television, ED, erectile dysfunction, where men are unable to have penile erections. And when I was first in practice, I would talk to the salesmen who were selling the brand new weenie pumps, as I would call them, which were little machines that would inflate the penis with the help of vacuum, and then you put a rubber band on the penis to hold the blood in, and we don't need them now. We don't need any treatments for erectile dysfunction, because if we can normalize blood sugars, we see it improving. Now, to give you an example of comments from people, a typical comment from a man would be, I'm beginning to get erections again, but they're still not lasting long enough. And that might be after only 2 weeks of normal blood sugars. And maybe after a month, I'm able to have intercourse, but it still doesn't last long enough. And after 3 months, it's lasting, I get the comment, it's lasting longer and longer. By the end of a year, things are virtually back to normal. But again, this means you have to have normal blood sugars. So I have never had to rely on devices, injections, special injections, any kind of medication for treatment of erectile dysfunction in my patients. There are other kinds of neuropathy. We've talked about gastroparesis before. That's a neuropathy. The problem with that is that although it gets better, for whatever the reason, it takes years for it to totally reverse so that you could get normal digestive function. There's diabetic cystopathies, where you may have urinary incontinence, where you lose urine inappropriately, or where you have difficulty initiating a void, etc. You can even confuse, in a male, cystopathy with enlarged prostate, both of which can make it difficult to initiate urination. There are symptoms of neuropathy that can be confused with musculoskeletal symptoms. For example, we talked in the past about carpal tunnel syndrome, which is a neuropathic sign. It's pressure on the carpal tunnel in the wrist, but it's really a musculoskeletal complication because glycosylation of this fibrous band in the wrist is pressing on a nerve. So that's not strictly diabetic neuropathy. There are things like double vision, where the patient sees two instead of one, but the brain usually corrects for that, and the patient doesn't even notice it. But if you put a red filter over one eye and have him look at a dot of light, he sees two instead of one. So it's rare that they have double vision that interferes with everyday activity. There are many neuropathies that I detect on a physical examination that really don't affect with living, like loss of the hippus reflex, HIPPUS, which you can read about on the internet. The neuropathies are usually the first diabetic complications to appear, and they are reversible. By the way, another kind of neuropathy that I frequently see is inability of the feet to sweat. Here, a patient will come in with dry feet, or may come in with dry scaling feet, where the feet are so dry that the skin flakes. Now, if the dry feet are mild, or if it's just a dry heel and slightly moist forefeet, front of the front feet where the toes are, it's reversible. And I have many patients who come back for a physical exam after a year, and the feet are now moist, which is, to me, a great improvement. So that sort of thing is reversible. But if the person had dry, scaly feet all over, then the cells that are involved in perspiration are probably dead, and because if you don't innervate them for long enough, they're going to die, and I don't think those cells are going to come back. So you could get permanent dry feet that's not reversible if you've had this condition too long. And as a rule, the neuropathies work something like that. There's one important neuropathy that I should mention, and that is the one that causes postural hypotension. There are arteries in your legs that are supposed to close down when you stand up so that blood doesn't pool in your legs and cause you to pass out by depriving the brain of blood. But for many diabetics, the nerves, the sympathetic nerves to the arteries in the legs aren't working, neuropathy. And when they stand up, their blood pressure drops. That's why every new patient who comes in here gets tested that's their blood pressure measured supine and then standing. And we look for a blood pressure drop, and many of them will say they feel like they're going to pass out when they stand up. And this can lead to major problems because the medical profession loves to intervene when a patient has what's called near syncope or syncope, which is syncope is fainting or passing out. So if someone stands up and they think they're going to faint, many doctors will try to intervene, send them to a neurologist. And we had a case where we found this in a new patient, and he had a large drop in blood pressure when he stood, felt like he was going to pass out. And I warned him, when you get up at night, if you have to go pee in the middle of the night, sit at the edge of your bed for a minute, dangling your feet, and get up slowly so that you don't pass out on the way to the bathroom. And this guy was doing fine. He had really normal blood sugars after we started to treat him. And one night he forgets to dangle his feet. And he's walking to the bathroom, passes out, hits his nose, gets a bloody nose. The wife is hysterical, but she's with it enough to check his blood sugar, which was normal. So he comes to, sits up, ends up going to the bathroom, and she calls her son, who's a doctor. He sends him to a neurologist. She doesn't call me right away. She calls me after he's seen a neurologist who had his carotid arteries tested, and a sonogram showed that they were 70% occluded. So the neurologist has made an appointment for him to go to the hospital to get an endarterectomy, to get his arteries reamed surgically. And I talk to the neurologist, plead with him. I say, you only do endarterectomies if the patient has what are called focal signs. And he says, well, he had a focal sign, he passed out. I said, did you check his blood pressure supine and standing? And the neurologist said, no, it's not necessary. I said, well, I did, and his blood pressure plummets when he stands. So this is not a focal sign. This is a neuropathic sign. He has neuropathy in his legs. And they wouldn't listen to me. I warned them, I warned the family, and the man had a stroke on the table and came back with a droopy lip and difficulty speaking. So the endarterectomy caused a mild stroke. Comes home, he's doing fine. A year later, he does exactly the same thing. We go through everything all over again, just like before. And I said, don't forget that this time you could kill him unnecessarily. And by the way, the endarterectomy did not change the postural hypotension. Of course it didn't. In any event, they went through the same thing, disregarding what I told them. Even the son, who is a doctor, granted a pediatrician, not a neurologist, went along with all this, and this time he has another stroke and surgery, and he's unconscious for 6 months before he dies. Caused a lot of distress, a lot of heartache, a fortune in medical expenses, and all totally avoidable. How often this happens, I don't know, but I'm willing to bet it happens quite a bit. This particular patient was treated by a team of physicians from a major medical school, and a world-famous medical school, and this is the inability to recognize a simple diabetic neuropathy. There are many more neuropathies, but I think we'll stop here to tell you that these things are usually reversible, especially if you catch them early. Before you sign off from this session of Diabetes University, take a look at my book, Diabetes Solution, which you can view at the site listed below, or you can purchase from any online bookstore. Also, visit my monthly seminars, teleseminars. The site for getting these free seminars is listed below. You can also join the Diabetes Forum, where you can ask questions to other diabetics who have read my book and have been using it. And one last thing is, if you go to the teleseminar, you can ask questions which I will answer, if not the same month that you ask the question, within a month or two thereof. Thanks.